these types of analyses or someone to explain it in a way that makes sense, because I think with the two trials right now, a lot of the momentum seems to have been sucked from the field, because the simplistic way of looking at this is that weren't these devices designed to treat, HFpEF, and we have two negative trials. But I think it was really nice the way you summarized it. Greg, any thoughts on some of these phenotypes?
Yeah, I mean, HFpEF is a lot more complicated than HFrEF. Okay, and we went into this, I think, a little naively, saying, well, they both share increased left atrial pressure, and so let's just reduce the left atrial pressure. But when you look at the cardiac structure and function of the heart, the question is, can they tolerate the shift of blood from the left heart to the right heart? And we didn't get to show in detail the changes in echocardiographic data, but basically in RELIEVE-HF2, the patients with HFrEF were able to tolerate that 1 liter per blood minute extra shift from left to right, and the RVs didn't dilate, the pulmonary pressure stayed the same, cardiac output was preserved. But the HFpEF patients, they could not tolerate it. Their ventricles were stiffer, they were more non-compliant, and the RVs dilated, there was more TR, the IVC got bigger, the pulmonary pressures went up by about 6 millimeters of mercury, and the cardiac output went down. Now, I think Sanjeev is actually absolutely correct. We enrolled a much sicker patient population, even then in the entire reduced SLAP HF2 trial. You required a really normal right ventricle. We allowed mild right ventricular dysfunction, a TAPSE down to 12, and an RV-FAC of 35%. And so you also required normal cardiac output. We had mildly reduced cardiac outputs around, up to about 4 liters per minute or so. And so I think that any sort of sick HFpEF patient is not going to do well with a shunt. The question is, I think, can you find a low-risk HFpEF population? And in reduced SLAP HF2, there was 1% mortality at 1 year. Incredibly low-risk heart failure population. Can you find this low-risk HFpEF population based on exercise hemodynamics, who then you get rid of the pacemaker, get rid of the latent pulmonary vascular dysfunction, et cetera, who then may benefit from a shunt? And so it'll be fascinating to see the results from these ongoing trials.
Any other thoughts? Yeah, go ahead, Robert.
Maybe two quick questions. One, any insights you can provide around changes in medical therapy over the course? And then two, the quality of life data. We see this kind of uncoupling then. Any insights around that were worse clinical outcomes, but the quality of life measures no difference?
Yeah, the medical therapy was excellent in these patients, and it changed relatively little over time, except for SGLT2 inhibitors, which was approximately 45% of the patients at baseline and increased to about 55 to 60% during the 1 year follow-up. And in the publication, we'll have all of this data. The divorce of KCCQ from cardiovascular events is fascinating and nuanced. Major placebo effect. And it shows you, I mean, patients, it's a human condition. They want to feel they're getting better. And they went through a procedure, this was a lot of procedures, a lot of testing they go through, all this consenting, and they feel that they were getting better, even if they then ultimately have adverse events. So I think we have to really rethink how we use KCCQ in these trials.
Certainly lessons beyond this trial as well. Any other questions? One question just to Sanjeev, in terms of the phenotyping, I mean, it's not so straightforward to do exercise right heart caths, I mean, in even advanced centers. So is there some better way that we might be able to phenotype to get some view of some of these surrogates?
Yeah, I think, so you clearly weren't at my talk yesterday on exercise right heart cath, where I said that interventional cardiologists do things like tricuspid valve interventions, but they can't do a exercise right heart cath. I think you can. So one lesson is we need to do more of it. But the second thing is that, I think exercise echocardiography, if you look at RV free wall strain, and as we get more automated and AI techniques, I think we're going to be able to find ways that we can non-invasively, we still have to exercise, but non-invasively estimate peak exercise PVR. The other thing that's interesting is that in reduced LAPHF2, just back to the KCCQ, the patients who didn't do well, the non-responders, also had a big difference in their KCCQ. So there it was concordant. So really interesting that in one trial there was more concordance, in the other trial there wasn't.
Yeah, great points. I certainly think that people that attended your talk probably still don't know how to do it even after the talk, even though the talk was phenomenal, as I would expect. So thank you both. Greg, thanks. Sanjeev, thanks. And we're going to move on to the next trial.